Just let me know when. All right. Welcome to this Saturday's session. We will be talking about pelvic venous disease. We have a fabulous lineup of both presenters as well as panelists to give their expert insight and opinion on several conditions as well as cases. First of all, I would like to thank our generous sponsors, Boston Scientific and Medtronic, for sponsoring this webinar series over the past year. My co-moderator, Dr. Sara Skjonsberg, may join us. She is on call, but if she can be here, she'll be here. Otherwise, we will keep going for the next 75 minutes. Just briefly, I will introduce our presenters. They can say just a couple things about themselves when they give their presentations, but we have Dr. Kathleen Gibson, Dr. Julianne Stoughton, Miss Sara Skjonsberg, and Dr. Tanja Ebanks as our presenters today. We also have as distinguished panelists, Dr. Gloria Salazar and Dr. Kathleen Ozbath. So thank you very much for everybody being here today, and I look forward to learning from all of you on this important topic of pelvic venous disease. To get us started, because we do have a lot of content, we need to hear two videos from Vein and Lymphatic University Presidents and CEO, Dr. Lowell Kabnick and Dr. Victor Canada. So Gustavo, if you could play those videos, please.
Buenos días, queridos amigos. Yo soy el doctor Victor Canata, presidente de Vein and Lymphatic University. La plataforma y el grupo de trabajo de Vein and Lymphatic University es un grupo de profesionales de alto nivel a nivel mundial que se encuentra desarrollando programas de enseñanza, de capacitación y de preparación de diferentes tipos de webinar, trabajos humanitarios y enseñanza en el campo de las varices y los linfáticos. Este grupo de trabajo tiene una calidad y una capacidad excelente. Nos encontramos permanentemente trabajando en demostrar la excelencia y la capacitación de todas las personas dedicadas al tratamiento de las varices y de los linfáticos a nivel mundial. Por eso les decimos y les agradecemos al grupo de trabajo. Les pedimos que nos sigan en nuestras plataformas y en nuestros diferentes webinars y que se acerquen al grupo de trabajo de Vein and Lymphatic University. Generalmente lo manejamos en forma compleja, teniendo la posibilidad de demostrar el trabajo de las diferentes diversidades etnológicas, demostrando las capacidades científicas a nivel mundial. Así que, por tanto, les doy la bienvenida y espero que nuestro trabajo tenga sus frutos en relación a la capacitación, la calidad de la enseñanza y así como también la llegada a nuestros diferentes pacientes a nivel mundial. Así que un fuerte saludo para todos. Por favor, recuérdense de que la capacitación y la enseñanza es algo que realmente nos va a ayudar y va a demostrar que nuestros pacientes cada vez reciban mejores diagnósticos y mejores tratamientos en el arte del tratamiento de las varices y los linfáticos. Un saludo para todos y que Dios los bendiga.
Hello, everyone, and welcome to today's session. My name is Dr. Lowell Kabnick, and I'm the chairperson of Vein and Lymphatic University. VLU is a premier educational platform whose mission is to deliver groundbreaking, high-quality content utilizing the talents of a diverse global team of health experts focusing on venous and lymphatic disease and treatment for the medical community and its patients. The goal of VLU is to make a positive impact on the global medical community by accelerating venous and lymphatic education through highly accessible and interactive live webinars and lectures, informative videos, and other premium channels of community engagement with the aim of empowering, inspiring, and advancing understanding of venous and lymphatic disease and treatment. Our initial series is titled EmPowHER, which was developed by Ruth Bush, Sara Skjonsberg, and Leanne Alizio. This is a series of webinars crafted and directed by our women colleagues for all. On behalf of VLU's Executive Board, we thank you for joining us.
All right, well, thank you very much to our sponsors, and we will go ahead and get started. So we'll start with Dr. Gibson. If you would just state, Dr. Gibson, where you are and maybe just a sentence about your experience with pelvic venous disorders and then your presentation. Thank you.
Sorry, the international sign for mute, you're muted with people waving at you. So I'm Kathleen Gibson, and I am a vascular surgeon in the Seattle, Washington area, in Bellevue and Kirkland, Washington. And I've been treating women with pelvic venous disease for a number of years. Initially, when I noted that some of my varicose vein patients had vulvar varicosities and pelvic pain. And so that's kind of really where my interest started. Not anywhere else. I wasn't trained this at all in the 1990s, wasn't on my radar. And so hopefully sessions like this will help get it on everyone's radar, and that the training and recognition will come earlier than it was for many of us. So my talk today, and I'm going to try to share the screen, is going to be differentiating endometriosis from pelvic venous disease. And let me try that. And then I'm sure my co-webinar guests will let me know if that is not working. Share screen. Here we go. Okay. All right. So everyone can wave their hands and tell me if they can't see that, but I think it's okay. I'm seeing thumbs up. So endometriosis, something like pelvic venous disease that I was never trained about. I knew people that had it, but knew very little about it. These are my disclosures. And endometriosis, it is endometrium in an extrauterine location. It is inflammatory. It is a very common cause of pelvic pain, and it's estrogen dependent, and a common cause of infertility. It impacts up to 10% of women in the US of childbearing age. And I think I missed one slide. Chronic pelvic pain, backing up, can have many different causes. And endometriosis happens to be the most common diagnosis of pelvic pain. But right up there in this list is pelvic venous disease, although there are a number of OBGYN groups and societies that don't think that it's a real entity. And so this is an area I think that we've got a lot of work to do. In terms of venous cause for pelvic disease, there was a seminal paper by Beard in 1988 that I encourage you to look up that had 3 factors which were 94% sensitive in diagnosis of pelvic venous disorder. So postcoital pain, so not pain during intercourse, but after, sorry about that, ovarian tenderness, and unusually distributed varices. So that would be, and I'll show you some photos, some extrasaphenous varicose veins or vulvar varices. And then we saw this slide already. Let's go on. So how is endometriosis diagnosed? It's diagnosed by bimanual exam, something that most vascular specialists won't do, but I think that a patient must have had if you're going to treat them. And then the imaging includes transvaginal ultrasound, MRI, which is shown on this slide, or laparoscopy. And treatment is oftentimes hormonal, medications, pain meds, hormonal contraceptives, etc., or surgical to remove implants and fertility treatment. And I apologize for these slides. They have timers on them that I didn't erase, so they may flip back and forth a little bit. So I apologize for that. So I made this table kind of to differentiate, when I was reading about endometriosis, some of the differences between this pelvic venous reflux, which would be pure like ovarian or gonadal reflux, pelvic obstruction that can sometimes cause pelvic pain, either thrombotic or non-thrombotic, or a mixed picture. So one of the differences is endometriosis can occur anytime from puberty on. So a patient will not have had to have children, whereas most of the patients we see with pure reflux disorders have had multiple pregnancies, usually 2 to 3. Pelvic obstruction can occur at any age, but is more common in people with low BMI. And a mixed picture often happens after pregnancy. Endometriosis, those patients do not have any more or less incidence of varicose veins than anyone else. But we do see vulvar varicosities, particularly, and leg varices with pelvic reflux, and sometimes also with obstruction. Edema is not a feature typically of endometriosis or pelvic reflux. Pelvic reflux, again, you see an increase with parity. Dyspareunia can happen with almost any of these disorders. And one very important thing, pelvic venous disorders do not increase risk of ovarian cancer, whereas endometriosis does. So when should you be suspicious of a venous disorder? Well, first off, I think that the other gynecologic pathologies need to be evaluated or addressed. That's one of my first questions. If a patient comes to see me that's not referred by an OB/GYN is, when was the last time you saw them? And I insist that that be done beforehand. If they've got a history of vulvar varices or hemorrhoids like seen here, and these are some of the non-saphenous distribution varices I was talking about. This is anterior, medial, and posterior pattern. Flip through those fast, sorry about that. Go through it a little slower, anterior, medial, and posterior pattern, okay? Also, the patients often have venous type symptoms, heaviness, aching, postcoital pain, urinary frequency, and they can be worse with menses, even though we say this is a non-cyclical pain. So what's the pathology? Well, you can have a compression or a stretch of the left renal vein across the aorta. You can have reflux down the left or right gonadal veins, more commonly left. You can have obstruction of iliac veins, more commonly the left common iliac, that's non-thrombotic or thrombotic. You can have reflux down one or both internal iliac veins. And all of this, any one of these pathologies can cause pelvic pain, which can be confusing because you can have different anatomic lesions produce similar symptoms. So here is a video of left renal vein compression. You can see a jet right here. And then what you'll notice is that the contrast goes quickly out of the pelvis and up a compensatory right ovarian vein. So for me, when I see this pattern, I think obstruction. And down here you see a stent. This is a lady I had that had had a post-thrombotic occlusion of her iliac vein that had been stented years ago and was having flank pain and some pelvic pain. Then this is primary ovarian vein reflux. You'll have to take my word for it that the renal vein's okay. But what I really want you to look at is how long the contrast just sits here. So this woman had no compression syndromes at all. This is just contrast hanging out in the pelvis for a long time. So this is a different picture. And then this is 3 examples of compression or 2 examples of compression and 1 a thrombotic occlusion causing dilated veins in the pelvis. And all 3 of these patients also had pelvic pain as well as leg pain and leg symptoms. Okay, so a case example, 38-year-old female, and my pictures aren't beautiful with this because this is the only patient I could think of with endometriosis and this disorder that I've seen recently. So she started having pelvic pain after puberty, severe, treated with hormones. She had laparoscopy and diagnosis of endometriosis, which was treated, and then got better. But after her 2nd and then 3rd pregnancy, she had increasing heaviness, aching, urinary frequency, dyspareunia. Everyone said, okay, it's your endometriosis again, but came to me saying the pain felt different than the pain she'd had before. So on ultrasound, we found compression of her left renal vein, but I'm going to show you some pictures about how this velocity ratio was not significant after we turned her on her right side, which we often do as we position them, we stand them or turn them. She had some left iliac vein visual compression, but the velocity ratio was less than 2. So we did not think that was a big deal. A dilated refluxing ovarian vein on the left and a normal right ovarian vein. So her SVP class, which is another talk in of itself, is listed here. So that's how we often use or classify pelvic venous disorder patients. So this was her renal vein supine. You can see that visually it looks like a stenosis. And then if we turned her, this opened up. And I'm not going to spend a lot of time on here, but I recommend doing positioning, and maybe Sara will talk about that in her talk a little bit. Left ovarian vein was dilated 12 millimeters with reversal of flow. Right ovarian vein looked normal. This is, I just have still shots on her, not cine. This is her left renal vein, emptied fine. The beginning of the run on her left renal vein. And she had this little blip here, kind of like a varix, that my glide wire punctured when I went down. So this is extravasation, but no big deal. Didn't feel it, did fine, went ahead and treated her. Here is a occlusion balloon looking into the pelvis. She mostly had veins on her left side. She had coil embolization and sclerotherapy in the pelvis. And then her right vein, I had trouble getting this to reflux at all, was normal. Okay, so quickly go through my pictures, which aren't great pictures anyway. But afterwards, she had 2 weeks of crampy pelvic pain that was relieved with nonsteroidals. And her symptoms largely resolved by 6 weeks, except for she still has some urinary frequency. So in summary, both endometriosis and pelvic venous disorders can cause chronic pelvic pain. The pattern can be different. The patient's history can be different. You need to listen to them. Identification, you need good diagnostic skills and good history and physical. Understand the anatomy, use your SVP classification. There's the plug for that. And our next steps, I think, is going to be showing the world that this is a real entity by having a dedicated patient score that will pick these patients up and maybe differentiate them. Thank you.
Wow, that was a ton of information and incredibly interesting. And even if you've said the pictures weren't great, I thought they were fabulous. So I'd love to hear from our panelists or any of our presenters on comments about the case. So you talked a lot about have a very good working relationship and educate your OBGYNs, who are the ones who will be seeing these patients to begin with. I have some type of pelvic pain. That's, you're either going to go to your primary or to your a GYN physician. So number one, can you tell me about your relationship with the gynecologist and how you started that? And then I'd love to hear from Dr. Ozbath and Dr. Salazar.
Yeah. So I would love to tell you that it's all wonderful and they all send all their pelvic pain patients to me that have venous disease, but some of them in my community still don't buy it. So the first group of patients that, again, that I see are either self-referred or they have vulvar varices. And I think when a patient has vulvar varices and a primary care doctor or OBGYN sees that that's something real and quantifiable that they can see and say, aha, I don't treat that, and send to me. And oftentimes they do have pelvic pain. I do have a kind of growing group of OBGYNs in our pelvic clinic too, which is nice, that will refer to me kind of as I'm the last resort, though sometimes I think that they go through everything else first. They've almost all had laparoscopies before they see me. But there's, I think, more and that I'm seeing because patients report back that they feel better. But again, this is something where we really need to be supporting. I know that there's some upcoming trials to prove that this is show that this is an entity, because I think that the feel better, if you don't believe in it, you can always say it's the placebo effect or something like that. So we need to really get some good evidence out there. I think those of us that treat it know that it's real, yet we don't want it over-treated either. We don't want this to become something where someone sees a dilated vein and laparoscopy and patient with minimal symptoms gets treated. But long-winded answer. I'm interested to hear what other people have to say about it.
Great, thank you.
So welcome everyone. Thank you for having me. I agree with Dr. Gibson's perspective on the gynecology collaboration. I think there's some hesitancy not hesitancy, but just not lack of awareness of understanding disease. And I think that the problem also becomes then when you see those dilated veins and everybody wants to treat it, but in the absence of symptoms is not appropriate. I would tell you I have a different perspective because I am an interventional radiologist and I do work a lot with a gynecologist for other reasons. And of course, I was at Mass General before with Dr. Stoughton, and then we have a collaborative multidisciplinary vascular center, which is also different than most places. And we do have, Dr. Stoughton has a very great collaboration with gynecologists as well as, the IR team. So I think I have a little bit of different perspective. Now that I've been at the University of North Carolina, the first thing that we're doing is really working on women's health issues with the gynecologist. And then as a result, they refer to us for pelvic venous disease. But the pelvic venous disease is really coming from vascular specialists, vascular medicine doctors, more and more. And I think that speaks to the education or the awareness and the better understanding of the disease. So that's how I get my patients. But initially, when I was starting my career, it was from the vein practice and from my fibroid practice. Okay. The last thing I want to add is, and whenever and anytime there's a patient with endometriosis and pelvic venous disorder, I'm always going to have a working relationship with a gynecologist nonstop, because that's when you add value. The endometriosis is not going to go away. it's a terrible disease because there's no cure for it. You're going to take care of the venous part of that pelvic pain, and then you need to make sure that you're working very closely with your gynecologist because those patients recur for different reasons. And the differentiation of the pain from endometriosis from pelvic venous disease is extremely important. So I love that talk, and I think that's really helpful for all of us.
Great, thank you. Dr. Ozbath.
I really appreciate, I love always hearing Kathy speak, and I always feel like I learned something. Kathy, I have a question for you, and I struggle with this a little bit in my practice. In patients who have renal vein obstruction to flow, I don't want to use the nutcracker word because that always seems to cause all kinds of emotional issues with people. But how do you feel is the best way to treat that in this day and age?
I think that first off is a recognition that many of these patients don't need it treated. That I think that the patient that I showed you the video of was one of the few that I've had in the last couple months that I think needs it treated. That I think that's the cause of her flank pain. And there's some other pictures I have that she also has pararenal varices around her renal hilum. So I think listening really to what the patient's symptoms are, because sometimes a patient, particularly when you're looking at them with venography laying flat, they will have a narrowing. But I think looking, like I showed you at the diagnostic study with the fast transit, to me implies a pressure gradient. And really listening to what their symptoms are. The lady I saw you, what I'm planning to do, she lives out of state and hasn't quite decided what she wants to do, but I'll probably do a gonadal transposition on her because her renal vein is 12 millimeters. And I think that I can swing it over pretty well. I mean, there's no one treatment that everyone says this is the gold standard of what you should do. People stents can migrate. Stents can erode. There's downsides to that. We don't have a renal dedicated stent. The ovarian vein, there's criticism that if it's not doing enough to decompress the kidney now, why would swinging it over be any better? I think it probably would be because you'd be dumping into the vena cava or iliac vein. People transpose the renal vein. People do auto transplants of the kidney. We don't know. We don't know what is best. I have not sent anybody for auto transplant. I don't know if any of you have. But mostly I've either done a renal vein and I haven't done the Mayo thing where you put the stent in and sew it to the vein, or put the stent in and move the vein. I haven't done that yet, but it's interesting. I've mostly done either renal vein transpositions or ovarian vein transpositions.
I find that first of all, it's really fun to do transpositions only because these patients are usually very thin and, they bounce back very quickly. And I've had a recent case where I did do that because I thought that was the main problem. She did fine initially and then came back again with recurrent symptoms. And it turned out that I really should have probably treated the gonadal vein at the same time, or just do that and see what happens. So sometimes for me, it's hard to really tell for sure which it is.
Yeah, and I've only, in the 20 years I haven't been doing it 20, probably 15. I've only had one person where I embolized the ovarian vein and then caused flank symptoms. I had that happen one time. And she recovered after 6 months. I imaged her and she developed some kind of ascending collaterals up her back, and pain had gone away. But she went from pelvic pain to back pain. And this was kind of early on in my experience. And I think I wasn't listening to her physical well enough when I look in retrospect, but I've only had that happen one time.
So I'm sorry, go ahead, Dr. Stoughton.
No, I was just going to say to that point, we actually looked at about a 10-year experience at MGH of patients that had embolization sclerotherapy without treating the renal vein compression. As long as they didn't have renal symptoms, they did fine. If they had renal symptoms, they kind of need to have something more definitive, but
yeah.
we found that was at least a safe thing to do.
And when somebody checks back pain on their little intake form, you need to really say what kind, because I mean, which one of us doesn't ever have back pain? Where is it? Because pelvic pain can also present as back pain in the sacrum. They can have low back pain, and that's different than the type of renal higher pain people get, the flank is higher, you know, that you really need to kind of drill down on where their pain is and things like that.
So that's a very good segue into the question that came to the Q&A. So I want to hear what you all have to say about that, and then I want to move on to Ms. Skjonsberg's presentation, because I think that this discussion will build as we go through the presentation. So to all of you all, who uses a patient symptom questionnaire or some type of screening tool to identify patients with pelvic venous disorders? I know you, Dr. Salazar, said most of your patients come from your venous practice. So I'd like to hear how you identify these patients.
You know, there isn't a validated specific questionnaire. There's one like Carl Black developed that some people use. There are some out there, but Neil Kilnani with the SIR Foundation and AVLS is got a it's now mostly funded to have a psychometrist go and interview patients that hopefully we will have such a thing soon. That's my hope. And, you know, even if it's not fully validated, maybe it's something that those who are enthusiasts can try out and use and see. But for me, it's just a really good history at this point of knowing the questions I want to ask, but we need one.
Right.
Yeah. I'm actually on that group with Neil, and I think that will be great. But there is actually a validated from the GYN side. It's very generalized, but it's like 12 pages long. The International Pelvic Pain Score, IPPS, or Pelvic Pain Society, IPPS, they have a free downloadable thing, but we've actually started to have the patients do it way ahead of time. And it kind of helps to screen out those endometriosis and the, you know, other kinds of etiologies that GYN people should probably see first. But that's what they use, and we've been starting to use that as well.
Great. So why don't we move on to Sarah's presentation? Are you going to for your screen, Sara? I think you had said yes.
Yeah, I'll share my slides. Let me get them up here.
All right, thank you. And if you'll just say what you looks good.
Okay, great. Well, good morning, everyone. Thank you so much for having me. I am going to come at this at a little bit of a different perspective because I'm a sonographer. So my name is Sara. I work for Organ Vascular Specialists currently. I got all of my pelvic venous training actually at the University of Washington with Mark Meisner. So I really have him to thank for all the knowledge base that I have, but it's been very helpful to share it as I've moved on in different practices. But so yeah, I'm going to kind of come at this more from an imaging perspective and kind of what we see initially before we send our patients to the provider, and kind of what we're reporting and seeing. I have no disclosures that are relevant to this lecture. So initially, I'm just going to kind of go through this case, and I have a few other cases that will be peppered in, and we'll just kind of talk through the pathology as we talk about this case. So this is a 27-year-old female. She has left lower quadrant pelvic pain, and she has painful intercourse and painful menstruation. So initially, in our pelvic venous evaluation with ultrasound, we look at the left renal vein. And as Dr. Gibson mentioned, I know that Lake Washington Vascular has done a lot of positional stuff with their patients. I'm not going to talk a ton about it because I'm still investigating it for myself after hearing one of their sonographers, Sarah, come down and talk. We chatted about it this fall. And I think that's one of the things that's really great about this field is that those of us that are doing pelvic venous disease ultrasound, we can kind of bounce ideas off of each other. So I'm still investigating that, but I'm very interested in it. So this is kind of the traditional duplex ultrasound, and this is a zoomed in image, and you can actually see the aorta in transverse, the superior mesenteric artery in transverse, and then you can see longitudinal left renal vein as it crosses between. And we take diameter measurements of that left renal vein. I like to use my zoom function here so that I'm actually zooming in on that renal vein, and I can see the walls really well as I can take a picture at the same time in the cardiac and respiratory cycle, because we all know that veins move. So veins will change. So if you're going to take a picture and actually use them for a diameter ratio, I think it's really important for us to do that at the same time so that we're comparing apples to apples. So you can see that our diameter ratio here on duplex was 7.5. So we're taking the largest diameter, which is the dilated diameter on the kidney side of the left renal, compared to where it's stenotic. And that's going to be important as we move on. This is this patient's velocity ratio. So you'll also notice in this image, traditionally in venous sonography, we haven't used angles. And that's something that we really want to make sure that we're paying attention to. We also really haven't paid attention to velocities in veins before. So as we're really dialing into a actual velocity, we want to make sure that we're using the same angle on both sides. So using that 60-degree angle, make sure, again, that we're comparing apples to apples. And here you can see the velocity jet just at that SMA and aorta crossing. And you can see a velocity ratio of 6.0 for this patient. And I do have just a little bit video just because I think that this is kind of the traditional way that we've thought about renal vein compression. Of course, nutcracker syndrome is a dirty word, and we'll kind of talk about that in just a moment, but I'll play this video real quick just so that you can hear it.
Renal nutcracker syndrome is when the left renal vein, which drains blood from the left kidney, gets squeezed between two arteries, the superior mesenteric artery and the abdominal aorta. It's kind of like the renal vein is the nut and the two arteries are the nutcracker.
So it's just a really short video, but I just think it's really cute to just kind of describe the classic presentation of nutcracker syndrome and how we thought about it once before. But now we're really discovering that this is left renal vein outflow obstruction. So instead of focusing on this nutcracker presentation, this SMA compression presentation that we've seen in most cases, where in this picture on the top, we can see that the left renal vein is stenotic at the area where the superior mesenteric artery and the aorta are actually compressing the vein. We've also found that there's other presentations that can lead to left renal vein outflow obstruction. So it's important for us to kind of dump that nutcracker term and really use more of an anatomic term as left renal vein outflow obstruction. I also want to point out here that I like to use outflow obstruction until we know that a patient's symptomatic for it. And Dr. Gibson talked a lot about that, knowing that a patient has actual kidney symptoms versus pelvic symptoms. So the second picture here with the arrow, you can see we can actually see right renal artery compression on the left renal vein. So we can see that right renal artery come up, and we can see our stenotic area within the left renal vein as it enters the IVC. We also have a left renal vein stretching, where we see, because of the position of the kidney, the left renal vein can become stretched over the aorta. And I'll show you a picture of this on duplex so that you can kind of differentiate between the two. More rarely, we see circumaortic left renal veins, where they actually go around the aorta. So you have two branches of the left renal system, one getting compressed between the superior mesenteric artery and the aorta, and then one behind the aorta, retrograde or posterior side of the aorta, in between the spine and the aorta. So oftentimes one of these can be compressed, not both. So sometimes you'll see the posterior side being compressed and the anterior side normal. And then lastly, we can have a retroaortic renal vein system. So the retroaortic renal vein crosses below the aorta and between the spine, and with a compression there. So case number 2 is a 51-year-old female. She has chronic pelvic pain, fullness and heaviness of the left lower extremity. She's gravid 6, parent 5. And here you can see on duplex that right renal compression. So you can see how the right renal artery, so aorta and transverse here in the center, and then we see our right renal artery come off, and then beautifully just up above that, we see our left renal vein very compressed just between that right renal artery. And I zoomed in on it here and tried to take a diameter. It's almost completely occluded, so it's really hard to get that on duplex, but you can see how compressed it is and how big of a comparison it is between the kidney side and right at that right renal artery. Case number 3 is a 30-year-old female with left flank pain and microscopic hematuria. So we're seeing more kidney symptoms here. And here we can see a stretching over the aorta. So we can see a longer segment on duplex that looks narrowed. So it's actually completely stretched and it's not at the superior mesenteric artery. So we're not seeing it right at that focal location, but we see it kind of more over a longer segment of the vein. And this is another example image of that where you can see it kind of stretched over. And you'll notice that, you know, this one is not as pretty of a picture, but it's important for us to recognize the difference in the anatomical differences of these compressions. So let's go back to the first case. So I just want to remind you that this was a left renal vein compression by the SMA. So kind of that classic presentation here. And this patient had pelvic symptoms. So if the problems with the kidney, why are the symptoms in the low pelvis? Well, this is a picture of this patient's left ovarian system. So you can see a dilated left ovarian at 1.15 centimeters or 11.5 millimeters. And you can see retrograde flow coming down over that psoas muscle and into the pelvis. So Kathy and I got the same memo here and used the same picture, but I think it's important for us to point out that the SVP classification paper kind of described pelvic venous disease as compensated or uncompensated. So if you have a compression of the left renal system or an outflow obstruction of the left renal system, it can be compensated by the left ovarian system, leading to pelvic varices, or it can be uncompensated and lead to varices at the kidney. Similarly, for the left common iliac vein, if you have a left common iliac outflow obstruction, it can be compensated by the internal iliac, and you can have varices in the low pelvis and sometimes even in the genitals, or it can be uncompensating, transiting down that left lower extremity. So this is a picture of that patient's venogram. So we have the left ovarian vein compensating, bringing that flow down into the pelvis, and the pelvic varices filling around the uterus. And then one last thing I want to point out about this is that on the duplex, we actually get a dilated measurement of the ovarian vein on the right-hand side. So we can see the psoas muscle here. We see the ovarian vein, right ovarian vein sitting right on top of that psoas muscle. And then we see the iliac vessels just next to that. So external iliac vein and external iliac artery here. And we actually have antegrade flow in this ovarian system. So now we have a left renal vein outflow obstruction that's being compensated by the left ovarian vein, presenting in pelvic symptoms because of the pelvic varices, and those pelvic varices are being compensated and drained by the right ovarian system. So just because we see a dilation there doesn't mean it's pathologic, it's just part of the compensation system. All right, I'm going to stop here for time and stop sharing my screen.
Those were awesome pictures, Sarah. I love the diagram and showing the ways the flow, and I like the compensation versus uncompensated, because I think that's what Kathy was alluding to in her presentation, or basically said, just because something is dilated doesn't necessarily mean it's pathologic or it's symptomatic. So for the sake of time, I want to make sure that we get our presenters and then we can leave some for discussion. So Dr. Stoughton, I'm going to move to you'd like to say where you are and what you do, and you're going to share your screen.
Okay. Let's see, I'm going to share screen one. How is that? Does that look good? Yes? Okay. I'm Dr. Julianne Stoughton from Mass General in Boston. And I have a little different kind of presentation for you all. I have some cases that we'll try to just go through however many it looks like we could have. And I think the first two speakers really laid it out really well as far as the pathology. And I think that's why I found why the gynecologists in my area don't believe in this entity, because some of the literature is just kind of, everybody's having the same procedure and sometimes it works and sometimes it doesn't. It's because they have different anatomy and their complaints aren't always relieved by one procedure. So that's why we need all of this awareness, and we need to put people into the right buckets and make sure that we are doing appropriate procedures for their anatomy. And the SVP is a good start as far as putting them into the buckets. So I just picked a couple of very interesting. One was an older case that I had some lessons learned, and I wanted to hear some discussion from people about what we might do differently, and a couple of other cases that, if we have time, when you have obstruction or reflux or whatever. So to go on, let's see, next. Okay, so I don't really have any relevant disclosures. So the first patient is a patient that has had really chronic pelvic pain and leg symptoms. And she has both lower extremity vein reflux on the left side, and she was found to have some proximal obstruction. So again, chronic pelvic pain is her primary symptom. So, the question comes up, what do you do first? If they have obstruction in the iliac or reflux in the GSV, which one do you do first? So this is a patient, sorry, I'm gonna just mute that. So this is a young woman, G2P2, had really significant chronic pelvic pain, dyspareunia, and very symptomatic left leg varicosities and leg swelling for probably 10 years. And it's gradually developed, but become worse with each pregnancy. Her pelvic symptoms are worsened with menses, but really all day when she's standing, she can't stand up anymore. She gets very significant groin pain. Again, no labial veins or hemorrhoids, but really almost. And what really, I want to jump down to the leg symptoms that she has. What really kind of got me was that she does have the usual achy, tired, heavy, swelling, hasty symptoms, basically, and pruritus, but she also has this almost bursting pain when she ambulates. So that was a key to me, that maybe her pelvic pain and this ambulation pain in her whole left leg sounded a little bit more like she might have obstruction. So we went ahead and did some imaging for her. Of course, first she comes in with a reflux duplex exam, and this was her reflux diagram, and it kind of lists here what she had. But basically, she had a very large anterior accessory saphenous vein into some very large tributaries, which you saw the picture on the previous slide. She also had reflux or reverse flow in her common femoral vein, and she had this kind of tributary coming up or down, I should say, from the suprapubic or anterior sort of pelvic escape areas. But again, no labial vulvar area veins or hemorrhoids. So this was sort of an anterior connection maybe to the pelvis, as Kathy was talking about earlier. So this was her leg ultrasound. And with her symptoms, I already kind of thought about the fact that we wanted to get some proximal imaging, but we did, this is again the duplex. I don't have to go through what reflux looks like, but her AGSV was pretty big and long enough that an ablation maybe would be in order. But then we got this this study, and let's see if it'll go. So you can see going from the bottom up, watch her left iliac here. It's going to come up. And it's quite big there. And then it really kind of, it doesn't look too bad, but then it really pinches right there. And that's the best pictures I could get. I think I do have yet another, these are not pretty, but as Kathy said, this was the kind of some recent things that we saw. So, and you can also see there's reversal of flow in her internal on the left side. So she's definitely, it's coming up the left and it's going backwards in her left internal and into the right internal. So let's go to the next slide. I think this also might show a little bit better some of the degree of compression. So if you can see, it really pancakes out. I'm sorry, it's going pretty fast here. She's also got some collaterals there in the groin, but watch that right there. It's pretty tight. So I guess the question is, what now? So she has this pretty tight left common iliac vein. Some people call it May-Thurner. We call it iliac vein compression. She has significant left lower extremity symptoms, but the symptom of bursting pain when she walks and the symptoms of the chronic pelvic pain from a lot of these venous collaterals that we saw both by ultrasound and you can see here on MRV. But she also has this AGSV that's coming down into the tributaries in her leg. So should we treat her leg and just leave her pelvis alone and see if anything improves, which I don't think it really would? Or do we treat her iliac vein first, or do we do both? I guess I want to maybe stop here and see what everybody thinks about what they would do.
Just feel free to call on people or just jump in.
Gloria, what do you think?
Presenters and panelists.
Dr. Salazar.
It sounds to me like her, the 9 out of 10 pain is her bursting pain with ambulation, which the anterior saphenous vein is not going to help. I would certainly advocate venography and IVUS with intention to treat if you found something significant, but let her know if you didn't find something significant, it would be just a diagnostic study and you go on to treat the leg.
Okay.
So it looks to me like this is a good case for that she's symptomatic from this obstruction.
It also may be the way that I presented it, but that is what our plan is. And I thought this was an interesting case because most of the time when I have somebody with a NIVL or non-thrombotic iliac vein lesion and some kind of lower extremity reflux, most of the time I'll fix the leg first because it's less, it's less invasive. I don't want to leave a stent in a 33-year-old woman if I don't have to. But I think for this woman who had primary pelvic vein complaints and this pain with ambulation and swelling significantly, I thought that she really wasn't going to get better from that if we fixed her AGSV. So we were going to do her iliac.
Well, I also think that the disease pattern of that you showed me of the lower extremity duplex would imply that it's from pressure in the pelvis for sure. If you showed me this picture of her leg, I would think that was GSV issue, primary GSV, which is garden variety.
Yes.
But this pattern to me says this is backward pressure from her obstruction
here. Yeah, that's another key that we made that decision. So anybody else that would do something differently or?
Well, clearly I would do the same thing, Dr. Stoughton, because we worked together for so many years. So I have nothing to add, but I agree this is quite different from just GSV reflux plus a NIVL lesion.
Yeah, so sometimes if I don't see this this common femoral reflux or deep vein reflux and these connecting pelvic vessels, and if they really have primarily leg symptoms when they're standing and they're fine when they walk, and they don't have a lot of pelvic pain, that would be a completely different, pattern. Okay, so that was my first case. Do I have time for another? I guess I have time for another. So this is the patient from 10 years ago who I saw, and I was like Kathy, I'm a vascular surgeon and never had any training in this. Obviously, it wasn't even an entity when we trained, but I was before you, but I got very interested in it and started to really see a lot of patients with pelvic pain. So she came to my office with chronic pelvic pain. We did a workup, and I'll show you what she had, but she basically had both iliac vein obstruction and gonadal vein enlargement and reflux. And really, it was a question of what do we do? Do we do the iliac vein and then we see what happens with her gonadal vein? Or do we do the gonadal vein reflux and see what happens with her iliac? So this is a 38-year-old woman, G3P3, chronic pelvic pain. She had very significant menstrual issues and postcoital pain. She did have we do have a good GYN workup done and gynecologists are not all the same. Some are very knowledgeable about pelvic venous disease and some really don't know how to manage or work up pelvic pain. So just make sure you do educate them, as Ruth was saying. So she had these symptoms in her pelvis, but no renal symptoms. She had bilateral leg pain, but actually more on the right and some swelling. She had no cross-pubic pelvic collaterals seen, and she had some small vulvar varicosities, but right side more than left, which we do commonly see. And she had a workup. Again, this was an older MRV, so it's not as pretty, but she did have pancaking pretty much of that internal, and then pretty significant, pelvic collaterals here, a little bit of a fibroid uterus, and then you watch up in here, this right groin and the right labial area. Actually, there's quite a few varicosities that are obviously probably from pudendal branches. Let me see if I have another. Yeah, so here's a really cool image. I love this. This is when the Ablavar was being used for MR venogram, but you could see there's a sort of a pancaking. You can't see it well in this view, but that's where there was just a very short segment that looked pretty close, and I'll show you the IVUS in a second. And then her big gonadal vein coming down, a lot of sort of perauterine collaterals, but then you see it kind of coming across into this vulvar on the right and sort of anteriorly into the groin on the right. So she had this anatomy. And we did at that point decide we were going to look at both and decide what we were going to do. So we did do, let's see, I thought we had, okay, so this is what we found in the procedure room. We did, again, the ovarian vein was quite dilated, and we did an injection there with sclerotherapy, and then we put some coils. And I apologize, they're not very pretty because these are interlock coils sandwiched with 3% SDS, which I used at that point, liquid mixed with contrast. And we occluded her left ovarian vein. And then you can see that there's no more flow down into the left gonadal vein. But before that was done, actually, I'm sorry, this was a little out of order. We did this venogram to assure that, you know, to see, just sort of look at the iliac. I was going from a jugular approach, which again is a lesson learned when you're trying to think about a stent in the iliac. But we did this venogram. It was a little bit pancaked. We did the IVUS, which is here. And again, this is starting in the external iliac vein. And then you can sort of see it's still, this is the iliac, and it's going up into the vena cava. So right around here, you're going to see it start to compress, and then it gets really tiny right here. So you can see how tiny, and then we're into the vena cava. So I was pulling from here up, and you could see that there was actually a really significant stenosis right around here. Maybe it gets really small. So I guess I should stop. You can sort of see what I did here, which was to put a stent in there. But I guess I'd like to ask the panelists, would you have stented this iliac, or would you have just done the ovarian, or would you just do the iliac? Let me ask you the questions now. I've kind of shown my hand, but I want to hear what, now this was 10 years ago, so I might have done something differently now, but tell me what you would have done.
I have two comments. I love the cases and I love the imaging. I think it's beautiful. I would say that anything having to do veins, it's all about expectation setting with the patient. The sweet thing about it is you don't have to do everything all at once. So you have absolutely no reason not to split it up if that's what the patient would prefer, or you can do it all at once, depending if you've had that discussion with the patient. I think in this particular case, today, I would more apt to go ahead and stent at the same time. 10 years ago, I would have done what, I would have just treated the gonadal, and I would have waited, and then I would have stressed about it, and I would have seen how she does and all that. But I think that in today's world, we have IVUS, we have venography that's readily available. I would probably treat both at the same time.
So I never treat both at the same time. I've got a kind of different idea about it. So the reason why is sometimes I would say probably maybe in this case, 10 to 15% of patients may need both. But if you intervene with both, you don't know what made them better. Number one, which one? You've got the risks of both procedures. And when I'm doing stenting, I typically will put them with no science behind it whatsoever on a Plavix or an anticoagulant agent for a period of time. When I'm doing embolization, I want the veins to thrombose. So you've got clotting competing with something you don't want to have clot. That's kind of my philosophy of not doing both at once. And I like to approach them differently. So I like to put in stents from the groin, and I like to coil from the top.
Yeah.
So if the patient was like losing their insurance, or I was positive both needed to be done, maybe, or we also don't do it in the hospital, so it's less expensive for them, their copay and everything. So I just don't. I know a lot of people do it that way. I don't think we have any answer, but that's my philosophy.
Tanya?
Oh, sorry. I just do the same thing that Kathy. I stage them, no matter what. Even if there are other findings other than the stenosis, I just stage them and see what gets better. Yeah, that's my approach.
I have to say that. Well, Tanya, do you have anything to add? I'm sorry, we haven't.
Sorry, no, I don't do stenting or coiling, so I'm listening, but I like the reason that Kathleen was saying that, one is clotting, the other one is the opposite, and you don't know which one has helped. And then just from before the last case that Julianne presented regarding to do the proximal obstruction first versus the vein, I would think, even though I don't do stenting, I would agree maybe how you presented it, but also kind of like going off the what we do with the veins on the legs, treat the most proximal and the most biggest vein first, and then see what happens.
Yeah.
Awesome.
I'm just sorry. I was going to say, I just to finalize, 10 years ago, I did do them together, but she had terrible post-embolization symptoms. And you're right. I put her on aspirin and Plavix, and yet I was trying to give her anti-inflammatories to help her pelvic, soreness from all this stuff. And I don't tend to do them together anymore. So that was one of my lessons learned. But okay, sorry. Ruth.
So I have one quick question, and then I want to go to Dr. Ebanks. So we have time for her presentation. But did her leg get better after that, or did you have to do the
Actually, well, I won't go through that, but her leg did get better until 4 years post-op. She looked pretty good. She had a few varices down here, but a lot of the proximal varices got better. And she had some hemorrhoids still. And then we followed her routinely with the stent. And then 10 years post-procedure, this is just a quick little, this was just a couple months ago. So she's got more veins back all of a sudden, but look what happened to her uterus. Now she has to go to Gloria's fibroid clinic, but you're not here anymore, Gloria. I need you. So she now has obstruction centrally, I think, from this big fibroid in her uterus. But she did do actually very well, and her leg did get better enough that she didn't need much more. Okay, sorry.
Awesome. All right, great. Let's move on to our last presenter, Dr. Tanja Ebanks. And if you just say where from and what you do.
Thank you very much. If you could maybe just run the slides, because I introduced myself here on the first slide, so that would be for IT, and then I later on go live again.
Gustavo, are you going to run them, or do I need to pull them up? Let me see.
Good morning, everybody, and thank you very much for inviting me to speak to you today. I am presenting a case with vulvovaginal varicosities. My name is Dr. Tanja Ebanks. I am working in the Cayman Islands. I have been trained in Switzerland in general surgery, and since 2007, I started with EVLT, and since then, varicose veins is about 30 to 40% of my practice. First of all, let's look at the vulvovaginal varicosities and the pelvic congestion syndrome. On the right side, we see varicosities of the left adnexa, which were very likely from the ovarian vein, where you can see there from the left side, the ovarian vein coming off the renal vein. And more likely, the vulvar varicosities pelvic congestion syndrome is on the left side because of the anatomy, as we know it from the nutcracker syndrome already. About the etiology of vulvar varicosities and pelvic congestion, that's quite poorly understood. About 4% in women will have pelvic congestion syndrome during pregnancy. However, most of them will disappear 6 weeks after delivery. Clearly, hormones are having an influence on the vasodilatation of the veins, same like we know it from the legs. And they do rarely arise from round ligaments, just like the varicocele if we find vulvar varicosities. In general, the symptoms include chronic pelvic discomfort, aching. It's usually left-sided, Standing, walking will make it worse. Patients complain about dyspareunia, and we can see enlarged distorted veins on the buttocks, external genitals, or thighs, which is typical how our patient here presented as well. Some complain of urinary urgency, and definitely during period, symptoms are worse. The diagnosis of varicosities in the vulva is mainly history and exam. However, diagnosis of pelvic congestion syndrome is a little bit more difficult. Usually we would go ahead and do an ultrasound Doppler. However, varicosities in the adnexa are not always symptomatic, and not all of the symptomatic patients will have varicosities there, and sometimes it's difficult to find why somebody would have pelvic period pain or pelvic pain during the period. CT or MRI can help if there is an outlet obstruction or some other anatomy to rule out other problems in the vein, in the pelvis. And venography is a very good tool if there is also the ability to coil and to treat if at the same time some varicosities are found in the pelvis. Treatment of vulvar varicosities include compression, elevation, especially during pregnancies. Try to relax and lay down, don't stand too long. Stockings may help. Conservative treatment otherwise, that would be after pregnancy if continue to have a lot of pelvic congestion syndromes as well, not just the vulvar varicosities. Can be hormonal with progesterone, Lupron or Soladex. If there is a GSV reflux, then we would treat that one first and hope that maybe that will improve the situation. There is sclerotherapy, staphylopectomy, which is used for the varicosities in the vulva, embolization from the either inguinal or jugular axis of the ovarian vein, or if patients are not getting better because recurrence is common as well as it is in the veins in the legs, sometimes total hysterectomy is necessary. I'm presenting to you a 39-year-old female. She had complained of varicose veins mainly in her legs, also in the right vulva for about 10 years. It got worse during pregnancy. She had her first pregnancy in 2013, and after the last pregnancy, the varicose veins didn't really disappear a whole lot after delivery. She moved from Chicago to the Cayman Islands in July last year, and that may have added to the worsening of her symptoms. She complains of aching and throbbing pain. She has heavy and tired legs, left worse than right. She has some swelling of the legs, and the pain is worse during period. She also complained of dyspareunia and of aching pelvic pain mainly during the period. She has been managing fairly okay, but she needed to take Daflon and Advil most of the time during the period. She presented with both legs with extensive varicose veins on the dorsal sides, left worse than right. She also had varicose veins in the vulva, right more than left. There weren't a whole lot of varicose veins in the front, and she had good peripheral pulses, and there was slight swelling of the left leg. This is how she presented when she first came in October last year, and there was mainly left leg dorsal thigh varicose veins. Those ones continue actually all the way under the underwear there to the buttocks. And you can see as well on the left leg, on the right leg, there is a little bit of varicose veins, but not as bad. This is the presentation of her vulva when lying down. I just wanted to show you the difference between lying down and standing. Here we can see how the vulvar varicosities fill when she's standing, and on the inside of the vulva, you can even see more varicose veins that are hiding away. We did a pelvic ultrasound, and that didn't show anything much abnormal apart from a bit of mild engorgement of the veins in the adnexal regions on both sides with a trace of mild reflux on Valsalva. This is not something that is uncommon and doesn't necessarily mean that we can diagnose a pelvic congestion syndrome, as we were discussing prior. Here is the anatomy. On the right side, we see an ultrasound image of left adnexal varicosities. This is not our patient, that's just to give you an idea of what it looks like. And on the left side, we see the saphenofemoral junction and the epigastric veins, and also the external superficial pudendal vein, which is very likely the one that is causing those varicosities there in the right vulvar region. Her Doppler ultrasound of the lower leg didn't show any deep or superficial truncal vein reflux. We only found varicose veins which are incompetent, as we saw on the left thigh and the right thigh, and a little bit in the right vulvar as well. So since the veins symptoms are much worse than her pelvic symptoms, we started with treating the venous symptoms and see if that's going to make a difference. There was no truncal reflux of the right GSV, which may have made a difference if we had done the right GSV ablation, but as I said, there was only reflux in the veins in the dorsal thighs. So she was very happy with the leg improvement after 2 weeks. This is how she presented. She only had one period so far, so she still had a bit of the pelvic symptoms and has been managing with Daflon and Advil in the meantime, and is deciding if she needs and wants to do something different, because her main concern was really the veins of the legs. But I'm very happy to hear other colleagues or panelists who have experience with pelvic congestion syndrome treatment and also with vulvar varicosities. Thank you very much for your time, and let's hope for a good discussion. Thank you.
Great. Thank you so much for the overview and for presenting that case. You also make a great case for moving from Chicago to the Caymans. I'd love to hear from our other presenters as well as panelists just on what you might do if this person showed up in your practice and how you would evaluate them.
My next case to present was almost exactly like that. I almost thought it was the same patient, but basically the bottom-up approach is really certainly, yeah, Kathy's nodding her head. I think it's a very good way to go in that kind of situation, for sure.
What I was wondering is if she's mainly concerned with the vulvovaginal veins and wouldn't, because there's nobody here in the Cayman Islands that does stenting or coiling of the pelvic varicosities or nutcracker syndrome or anything like that. So I don't have the option to send her for treatment. We could do an MRI, we could do a CT, but then that obviously doesn't help. And with the vulvovaginal varicosities, I was wondering if somebody would be doing a crossectomy and tie off that branch there, or do injections, or do sclerotherapy, or which one, ultrasound guided, or just inject and see what happens.
I do a lot of sclerotherapy on those. It works very well. And the easiest for me is to get not directly on the labia, although I do directly inject on the labia, but if you can find a vein kind of in the groin fold area with ultrasound and get a nice, either a butterfly or something on it, and you can sometimes get it all the way through all the vulvar veins. And I, from below, used foam polidocanol is what I use. From above, I use Sotradecol.
Foam, I assume, or liquid.
Foam polidocanol is what I use. And
you
then
use 0.5 or 1?
No, 1% foamed. We don't have, 1% is the most you can get in the US with, unless you go to compounded, which.
No, I mean 0.5 or 1, I was asking.
1%.
Yeah.
1%. And they don't get much phlebitis. It's surprising. When I first started in practice, we would take them to the OR and do a general, put them up in stirrups and do lots of little incisions. It was horrible because the veins don't pull out like they do in the leg. I
thought, and I was like, I'm not doing this. There is this webinar. I will find some people who tell me.
No, don't do it. So the injections, when I first started doing them, I'm like, oh, they're going to get phlebitis like they get in the leg sometimes with injections. And they really don't. They do great, I think, for the most part.
And what is usually the amount that you would need for that? Maybe just 1-2 mils then?
The most I will use in a session is 10, but usually they don't need that much. But 10, that's what I kind of limit myself to, is if you're needing more than 10, then you're
10 cc just for the vulvovaginal veins?
Yeah, on both
Wow.
sides. But
Oh, both sides. Okay.
yeah, I mean, I think it was either Mel Rosenblatt or Mark Meisner that was saying that, because they do, I know Mark does, uses contrast first, gets in under fluoroscopy, figures out how much volume he needs. And he said that he's never been able to push foam beyond kind of mid pelvis. It does not go all over the place. It's like, I mean, when you think about how much foam we put in from the top, sometimes 10 cc's really isn't a lot. How about see Julie and Gloria nodding their heads? What do you guys use? How much?
I agree, 10 cc's, and I do the same thing, contrast under fluoro, and then see how much volume. And the challenge that I have is if there's any upper limit in terms of the sizes. I just worry about phlebitis, even though I never had it. But if it's a large varicosity, should we set for resection? Do we have an upper limit?
I don't. You know what? Because I would rather do a drainage of coagula with an 18 gauge needle than do I mean, I never want to do phlebectomy in the labia again. It's not fun.
Agreed. They get hematomas. They're
Yeah,
not happy.
yeah.
The only time
I
I've
do
really
love-
had to change coagulum was a biker. She was, the bike seat was bothering her, so I had to do evacuation of that. But
I've had to do
I
it
also
like
wanted to ask, how do you compress afterwards?
That's what I want to know. How do you compress?
two things. You can either do Spanx or padded bike shorts.
Oh, okay.
Padded bike shorts, and people like that, but they have to get firm ones. They have to shop ahead of time and make sure that they're not loose. But those are the two things that I use.
Dr. Ozbath, anything different in Albany?
I learned about Spanx from Kathy Gibson. So that's what I tell my patients to use. No, and I totally agree with everybody's sentiment about phlebectomy in that area. Oh my God. Thankfully, we don't do that very often anymore, ever. But no, I agree with everyone. And the other thing about the injecting the contrast to see the volume, I do that.
I don't have fluoroscope available where I would do it, or I would have to go to the office, to the hospital instead of. Is it something that the ultrasound guided would also be able to do?
It's fine. It's
Sure.
optional.
Yep.
I think it's optional. You don't have to. Just, I mean, if you limit your, if you stay 10 or under, I think it's very safe, personally.
So there is no area where you have to check to make sure it doesn't go into the deep system or anything?
It goes into the deep system, and you don't, I mean, I do use physiologic gas for my foam. I use O2 CO2 mix. So I don't know if any other people use room air, but I feel pretty comfortable. And when I go from above, I heard Julie, you use liquid from above. You use foam?
That was 10 years ago. Now I use foam. Yeah.
And I use CO2 foam when I'm going from above, because sometimes I use bigger volumes. And I know there's other people like Mark Meisner uses air still and doesn't have a problem. But, I think there's
I
no
generally use
data.
air.
What's that? Use air? Yeah. I mean, people don't tend to have problems. I use CO2 because we've got the little canisters in my lab. It's easy. Everything seems to work and most people don't have problems. So it's just be judicious, I guess. But I think if you
I have one.
It's okay.
I have one last question. We have 2 minutes remaining, unless there are any burning questions. Sara, your pictures are beautiful. My vascular tech cannot do those. What is your suggestion for, I assume all the panelists and presenters have a tech like Sara who does amazing images like this?
So
What would be your suggestion for training?
Yeah, so, this is definitely a steep learning curve. And I think that one of the things that we really focus on is just as providers, making sure that your sonographers are interested sonographers have the availability to education. The American Vein and Lymphatic Society, we have a lot of information. We're always there to help. We have a great group of sonographers that are always willing to help train. And, my email is always available. I have lots of questions that come to my email about training. And I'd say the American Vein and Lymphatic Society is probably the best place to start. That's where I got most of my training. And there's so many resources out there, so many sonographers that are willing to help. We also wrote a guidelines document for the Society for Vascular Ultrasound that's out there, and that has a lot of good tips and tricks too, that's free and downloadable just off of the Society for Vascular Ultrasound website.
All right, awesome. Well, we are at time. I'd like to mention that Sara Anida did join us, but she's on her phone because she's taking care of a patient. I would like to thank our presenters, Dr. Stoughton, Sara Skjonsberg, Dr. Ebanks, and Dr. Gibson, and our panelists, Dr. Salazar and Dr. Ozbath. This was a very interesting session, a lot of information. I learned a lot. I appreciate your expertise, and you're willing to take time on a Saturday and share with everyone. This will be recorded, or has been recorded, and will be on the EmPowHER website as well. So I'd like to thank our audience, both those that joined on Zoom, and then we stream on Facebook as well. So again, I don't know, the question came up is how many. We usually can see how many are on Zoom, but more on Facebook, because that's what people use these days. In any event, enjoy the rest of your day, and thank you all, and thank you to Dr. Kanata and Dr. Cabinet and Vein and Lymphatic University. Have a great day.